There are 1.3 billion people in the world with hypertension, and at the moment only half of those know that they have it. It's the leading indicator for strokes, heart attacks, and it's also frustratingly easily treatable. You can either make lifestyle changes and or medication, so it's a low-cost fixable problem, and so you may not realize that's happening to you, but you're effectively kind of really shortening your lifespan. Lifelight is just a piece of software that's running on your phone, and it's doing the job of a physical blood pressure cuff or a wearable watch. This is the thing. This is absolutely game-changing.
Welcome to The Conversation. In today's episode of Trail Blazers, Johnny is speaking to Laurence Pearce, CEO and founder of Lifelight. Lifelight's vision is to turn every device on the planet into a self-monitoring healthcare platform, transforming your phone into a blood pressure monitor. We hope you enjoy this conversation. Be sure to follow us on social and subscribe.
Why is blood pressure so important?
So blood pressure is probably the number one measure that indicates cardiovascular disease, and it's the most preventable measure for cardiovascular disease, and yet it's a problem that it's asymptomatic. You don't know you have a problem until you've measured your blood pressure.
It's often called a silent killer, right? So why is that? And is that is it true, or is it just a little bit of a hyperbole?
No, it's absolutely true. So there are 1.3 billion people in the world with hypertension, and at the moment only half of those know that they have it. And of those who know they have it, only half are actually being treated properly. So it's known as the rule of halves. And the problem is, you have no idea. There's no other symptoms that come with hypertension. But it's, like I say, it's the leading indicator for strokes, heart attacks in maybe 5 to 10 years' time. And it's also frustratingly easily treatable. You can either make lifestyle changes and or medication if you need it. And the medication now is some of the cheapest medication globally. It's all kind of, there are generic products, etc. So it's a low-cost, fixable problem.
So how much, you said it's asymptomatic, so how much damage could someone potentially be walking around doing without managing their blood pressure effectively?
So yeah, I think that's the problem, and it's really our kind of modern lifestyle that's the kind of underlying cause for this, and we're sort of seeing that as obesity is increasing, lifestyle changes, people are less active, they're eating more, they're eating the wrong kind of foods, and all of that has its kind of impact on the cardiovascular system, which is like a well-tuned machine. And if you think of like your central heating, trying to think of a kind of non-medical analogy, everything is precisely tuned, and the pressures in the system have to be within a certain range. So if you imagine your body like that, you have this very regulated system, and as your kind of diet and these other factors are kind of affecting it, the system begins to break down. And so you may not realize that's happening to you, but you're effectively kind of really shortening your lifespan or increasing a risk of a stroke.
Are there any sort of early warning signs that someone should be looking out for, or anything at all?
No, not in the case of hypertension. So, and that's the difference with other kind of sort of long-term diseases. You can identify them. So diabetes or others, you will have some symptoms that will be kind of beginning to affect you. But with hypertension, it's literally until you've actually measured your blood pressure. You might be having headaches or beginning to feel kind of lower energy levels, but it's really those aren't really kind of true symptoms. So
it's actually quite terrifying when you think that you could be walking around, as you say, completely asymptomatically, nothing appears to be wrong in the slightest, and you've got this ticking time bomb, for want of a better term, that's going on inside. And it occurs to me that there's a bit of a friction here in the experience with kind of blood pressure, in the sense that, I for one don't know if someone measures my blood pressure and they say, 130/80 or whatever, what does that mean? Can you provide a little bit of context to that?
And again, that's slightly unhelpful because it's complicated. There's two different numbers, and even in different countries, there are different guidelines and recommendations. So in the UK, for example, the NICE and NHS guidelines are if you're over 140/90, that's the big number on the top, systolic, 90, the diastolic underneath. If either of those numbers are more than 140 or 90, then you're considered potentially hypertensive. And so then the next steps would be to go to a pharmacy, have what they call ambulatory check, where you put a 24-hour monitor on, or you would go and see your GP. In the US, it's actually lower. It's 130/80, and that's regarded now as hypertensive. So that, again, is slightly confusing, even, knowing your numbers. Well, what does it mean? But basically, if you're below 130/80, you're generally okay. But it's also age-related. So I think over 65, the recommendations get slightly higher. But again, that's all quite cognitive overload for people to have to understand these different numbers, and why should it be different in America from Europe, for example. So it's quite opaque, really.
Yeah, it occurs to me. And also then presumably people would have needed a cuff in order to measure their blood pressure previously. And if they don't understand the difference between the numbers, or, for those that may not, could you give us a little bit of an explanation about the systolic, diastolic numbers? What do they mean? How does that all fit together?
Yeah, so very simply, the systolic is the number at the top, the diastolic is the number at the bottom, and basically, I'm trying to keep it as simple as possible for people. So it's that sort of, if the top one is more than 130 and the lower one, the diastolic, is more than 80, then you should be kind of taking some notice of it. And if it certainly went over 140/90, then it's definitely time to talk to your GP or visit a pharmacist. But I think the problem, kind of coming back to the friction, is you needed to have taken a cuff reading in the first place to know this. And it's almost by default that if you don't know you've got high blood pressure, why would you buy a cuff or have a blood pressure reading? So, and that's kind of the challenge, really, is finding, there are lots of like charitable campaigns, etc., about knowing your numbers. May Measurement Month is one that we have in the UK, for example, just to get people aware of these numbers, so that and that's generally run, it's a little bit kind of ad hoc. It's usually like a bus that goes out to a community. People have the blood pressure check, and then so what? It's like, well, what's the pathway from there? What do they do next?
Yeah, but it's also a bit of a chicken and an egg thing in terms of investment from a patient perspective, because if I'm walking around feeling happy as Larry and I don't perceive anything to be wrong, or in my mind, I'm like, well, I don't really need to get checked. I'm healthy as a horse. Yeah. So from that perspective, you can kind of understand where taking a trip to a pharmacist to get measured, buying a cuff, which is an even greater kind of barrier to entry. So to take a step back from all of this, where did your interest in all of this come from, and how did you find your way into, becoming involved in the blood pressure area, for want of a better term?
Yeah, it's an interesting journey. So so I'm a computer scientist by background, so kind of technical, but I've always been interested in kind of healthcare in the sense of prevention. So, how do we avoid people falling ill and getting sick in the first place? And, I've heard the term sick care mentioned, that we don't really have healthcare systems in the West. We have sick care. So everything, and to be fair to clinicians who do a brilliant job, they are trained to fix broken people. There isn't really the training around how do you educate the public and promote prevention. It's like, well, we'll wait for them to turn up with the heart attack or the stroke, and then we know what to do. But that's kind of not sustainable. So when you've got this kind of increasing percentage of people, they reckon about a third of adults have hypertension potentially now, and it's even higher in some countries. So how on earth do you deal with that many people? There needs to be a lot more, first of all, kind of prevention, but also self-management. So, that's kind of being a passion of mine, is to give people agency over their own healthcare, to really, instead of having that paternalistic, I'll go and see the doc, it's actually, you need to take responsibility for this. And if you can make lifestyle changes, you may be able to deal with this without the need for medication. Yeah,
it occurs to me that with more and more devices, wearables, things like that, there is a groundswell of people having more interest in taking charge of their own healthcare. And I think you've touched on something that's a very, pertinent point at the moment, where we do have that kind of sick care system where we are very effective at treating an acute problem, but in managing the build up to that, not so good. And a huge part of that is education. Where did the kind of want to do something really come from? Was there a kind of hero moment that springs to mind where you really saw this as a problem that you wanted to say, I need to fix this?
I think so. I mean, it sounds slightly cringy to make it personal, but my mother, probably about 20 years ago now, sadly died of an aneurysm. And this all kind of, at the time I was working in like sort of health tech research, and my kind of other day job, if you like, was doing work with hospitals, looking at kind of technology. And I remember that she had this first aneurysm in her flat on her own. And she had this BT pendant thing, which was like a really basic, crude alarm that you're meant to press if you have a problem. And so I said to her, why did you say she had this first kind of aneurysm? Luckily, a neighbour found her. And, I sort of said, why weren't you wearing your BT pendant? And she said, well, that's just like a cream plastic, ugly box. I'm not cattle. I don't have to carry this around my neck all day. And it just really struck me. It's like we have not considered human factors. We haven't thought about the kind of user experience in this kind of, that was the early days of like preventative, what can we do to kind of keep an eye on people? And so then I went down this rabbit hole of thinking maybe we need to like put cameras in every older person's apartment. And I thought, no, that's creepy. That's not a solution. And it was like an evolution of that idea to think, well, there are already like 10 cameras on average in every home, which is through our devices. So what if we could somehow harness the tech that people have got with their full consent and awareness without infringing on their privacy? So it's kind of, they have agency again around, I'm happy to be monitored or monitor myself, take responsibility for it. But without the kit, it's like, instead of plumbing every home with wires and stuff that is kind of obsolete within 2 years and needs to be replaced, people are buying and selling phones. Let's just use those and harness the high quality cameras. That was kind of the sort of the precursor really to my work.
I mean, it's something that in the user experience world you're hitting on that's so, well, it's frankly speaking, it's the way that things should be done, where technology almost becomes invisible.
Yeah, absolutely.
And it becomes useful in the sense that you shouldn't add another kind of layer or friction onto the experience. You say you're leveraging a piece of technology that's in everyone's pocket already. So how does kind of the next step unfold? What was you have this epiphany, you realize that there's this challenge. What's the next move?
I mean, it was probably quite a few years between that realization there's a gap and then seeing a potential solution. So I think it was around like 2011, 2012, I was over at MIT and I saw this new science of remote PPG and this idea of...
What's PPG?
So photoplethysmography, which is difficult to say after a few glasses of wine. But this basic principle it's very similar to like the wearable devices that we have now, the rings, and also in hospital you get the pulse oximeters, which they clip over your finger. Yep. Nobody had heard of those before COVID, and suddenly everyone knew about them because of hypoxia, of like reducing your blood oxygen level. But they all use this thing called photoplethysmography, which is about shining light, like little LEDs, into or through the skin and picking up a blood volume pulse. So when it's contact-based, you see this kind of waveform coming back. And the innovation with remote PPG, RPPG, is modern cameras can actually detect this from the surface of the skin remotely. So, I mean, potentially the cameras in our podcast right now, if we played back the film, we could probably figure out your pulse rate right now.
Oh, wow.
And so that was like it was a very Hollywood-style presentation. Literally, they showed like a cowboy movie, like a Western movie, and they had this actor lying dead on the floor, and they were able to show he had a pulse of like 71 beats per minute by looking at frame to frame through the movie and picking up this tiny change in skin color. And that was like the aha moment, really, because I then connected that with the growth of blood pressure wearables. I thought, what if, and it was like a huge what if, that if you could harness the cameras in phones to pick up that signal, turn that waveform into something meaningful. I had no idea whether this would actually work, but then maybe, just maybe, you could do more with it than just count the pulse. You could actually do blood pressure, because pulse on its own isn't really that valuable. It's kind of, literally you can just do it by putting a finger over your veins. So but the power of doing blood pressure like we say, is this kind of ability to detect something that, we talk about hypertension and cardiovascular disease, but it's also kind of critical to so many other conditions, like things like chronic kidney disease. It's kind of an element of where the body is beginning to break down.
So in terms of when people should start looking at their blood pressure, monitoring that, and providing a solution that means that people can do that using just their smartphone, when should people realistically start thinking about these things? I mean, is this sort of something that they should be doing on a regular basis from a particular age?
Absolutely. So when you look at like the certainly in the UK NHS, you have the health check. The introduction of that started from, we need to check the blood pressure of the population. Now, there's affordability around that. If you recall everybody, it's just going to be expensive. So the health economics said you're more likely to have an impact if you start with like over 60s. So they're kind of limited to certain age groups. In fact, sorry, it was over 40s. So I think it started from the age of 40 to have people come for a health check. The reason it covers more things like blood counts and so on was while we've got them in the GP practice, we might as well do a few more checks. But it's interesting that the primary driver was we don't know how many people out there have high blood pressure, and we need to kind of find them. But then that's the health economics, which is based on, it's kind of a rationing in a good way. It's like where do we devote resources most effectively? But actually, increasingly, you're seeing hypertension in younger and younger people. Again, sadly, because of lifestyle choices and poor diet, poor exercise. So you could argue it's something that you could start doing in your 20s. But then I kind of hesitate, because you also don't want to build up anxiety, because the other kind of epidemic we have is mental health. And we don't want to kind of have people like, I need to check my blood pressure every hour. It's like, if you needed that, you probably ought to be in hospital. It's kind of, it's just to have like the regular awareness of your blood pressure and to begin to think about what changes you can make and what effect they have on that blood pressure.
Yeah, it's a really interesting one that you bring that point up about mental health, because I do think in terms of, you touched on the fact that we've got a massive obesity crisis, and that's only getting worse. We've now got the kind of constant on state that everyone exists in with their phones, their devices. So ambient stress as a level, you don't want to add in another layer of anxiety onto that. Yeah. So, I mean, it kind of seems that sensible approach might be 20s, but I guess there's probably an education piece in here as well, somewhere along that.
Yeah, absolutely. It's also becoming aware of your personal kind of like how your physique or your body kind of works in relation to blood pressure. So if, for example, if you've been doing vigorous exercise, then your blood pressure will be elevated. So these numbers that you hear in the guidance, like the 130/80 in America, 140/90 UK, are based on resting blood pressure. That's really important. And so it's easy to become anxious if you've been rushing. Quite often you can go to a GP surgery, you've parked, you're stressed out, you run in, and then they do a blood pressure check and it's really high. It might be 150 or something. But that's what they will then tell you to do is go buy a cuff, go home, rest, and first thing in the morning, before you've had caffeine even, try and take a measure, do that on a regular basis for a week and take an average of those recordings. So it's quite hard to get that baseline, if you like. It's really important not to get panicky about taking a single measure, perhaps when you're full of caffeine and you've just been at the gym. So it's kind of, but it's useful to become aware of how different things, behaviors, and maybe like stress as well can be affecting your blood pressure levels.
Yeah, I guess even to a certain degree, environmental factors like where you are, if you're at work, if you're at home, if you're in an environment that stresses you out slightly more, these are things that also factor into this. So in terms of the technology and where you're at with things, how are you kind of bridging the chasm of this proposition? So we know that we've got this challenge. We need people to be more aware of their blood pressure. You've developed this amazing piece of technology from this presentation at MIT that you've seen, where you can see cameras being used to measure all of this and distill all of this insight. What kind of was that next step that you took? Yeah,
I mean, so it was the combination of the camera idea and the contact-based blood pressure and like the fusion of those, saying, well, could we combine those two, and then could we do that through the mobile phone? That proved to be a lot harder and took a hell of a lot longer than maybe the
It sounds simple,
sort of
far from.
entrepreneurial optimism thing. You know, it's like actually the reality of that is it's a long, hard road. And but thankfully, you know, so I was good at writing grants. That was something I'd been doing before, usually in partnerships with other people. And so before Lifelight and this journey, I was involved in some quite fun projects. Like the one was around emotion recognition, and we built this kind of interactive music kiosk for a musical museum in Rome, which was really fun. And kids would walk up to it, and it would start to interact and play music, and then the music would change according to their emotional reaction. So the words they were saying, their facial expression. And I just remember thinking, I love this, but what use is it apart from having some fun in some installations? And so that kind of experience gave me the confidence that we could do something. And it was like, how could we do something that's actually impactful, but using this kind of computer vision and these new emerging technologies? But then, so the grant piece, so went from doing grants like the music kiosk kind of project into, I could do a grant for this. Of course, that then takes time. You get it together. Finally, we got some funding, and we're able to. I used that to source some developers. We built a very, very crude kind of mock-up almost of this, but we had something that we could then show like a minimum viable product to clinicians, and that was like the wow moment really, because I remember some very supportive clinicians looked at this, and they'd been looking all day at reviewing different digital health technologies, and they almost sort of said, right, stop. That's it. This is the thing. This is absolutely game-changing, and we will help you. We'll do a big study, and you're going to need lots of patients. So they sort of said, well, what do you need from us? And what we needed at that point was lots of training data. So if you like, the kind of initial concept was based on a whole bunch of assumptions about how we think it might work. What you then had to do is gather the ground truth data, build the kind of training set. And that's been like our quest, really, after doing that, because the first studies we did, we just recruited loads of normotensive people, basically, because you just go out and say, come and have your blood pressure checked. And then they all sit in this like normal curve somewhere in the middle. And then the AI cheats. It just goes, everybody's like in the middle, 120 over 60, 120 over 70. And hey, I'm kind of right most of the time. But medically, that's useless. It's like you've missed all of the like danger points. You're just telling everyone they're healthy. So we then had to run more studies. So by that point, we'd got really good at writing grants and actually finding ways to fund this, because at the early stages, getting like VC or conventional investor money is really, really hard, because investors quite rightly need like commercial, they see the commercial risk of doing something. They can see the upside. There's technology risk. But we had just had so many levels of risk. It was the only way to get this started was to do grant-funded projects. So we became like a clinical studies business as I grew the team. So it's not like a conventional app business where you've got like app developers, UX people. We had that, but we also had to have people who knew how to do ethics approvals, how to design the studies, how to engage with hospitals, how to motivate research nurses. At one point, there were 80 research nurses working on gathering data for us. So we collected over 13,000 videos of patients' faces with a concurrent like blood pressure cuff reading, or maybe multiple readings taken during that sort of like a minute of video. And then it's only once we had all of that, we could really test, could this work? I mean, as you can imagine, there were lots of like mini failures along the way where you think you got there, whether it was like a grant bid that we thought, this is a slam dunk, we've got a great opportunity. It could be like grants are really competitive. So there could be some other grants that just pip you at the post and get like 2 or 3% more in the score. And then you're unfunded for the next 6 months. So it's like, what do we do now? And so there are always like plan Bs, plan Cs, and it's kind of, so there's that requires kind of the like mental endurance, if you like, of working through the kind of negatives. And the other is when you get just results that don't seem, you think, yeah, this is going to be great. We'd send the data off for a validation study. And then the results were like a big shock to us because we thought we were there, but we weren't. So there were lots of kind of like reboots, if you like, having to go back and, rethink what we were doing, redesign. Because there's like this myth, if you like, that this is all like a nice, steady, gradual progression. It's more like sort of circle back, retry something, reinvent a whole new way. All along the way, you're looking at like publications in completely different sectors. So we've had in the team over time like astrophysicists who are really good at listening to very small noises in amongst masses of noise. So they're like picking up a little signal in huge amounts of noise. And that's actually relevant to what we're doing with the camera. We're picking up this tiny little blood volume pulse while people are moving their head. There's like traffic going by behind them, the lighting's changing, all of this stuff. So there's so many different skills that we've had to bring into the mix to polish and perfect what we're doing.
Yeah, and I guess that's part of that resilience piece is the fact that it's obviously mission driven.
Absolutely, yeah.
You see a massive outsized return on the opportunity to improve the lives of patients and many, many people, millions, potentially even billions.
Potentially, yeah.
So, I mean, that's another part that I guess probably gives you that little bit more resilience when things aren't going so well and smoothly for you to say, no, we need to keep persisting and pushing forward.
And I think over time, we've had investors at a fairly early stage who've taken a huge risk really to invest in us, and quite rightly, they're really committed to what we're trying to do missionally as well as kind of for them financially ultimately. But also the team as well are very mission driven. So the kind of people who choose to come and work for us as a data scientist over maybe a more lucrative job in a bank, over time you're kind of building this crew of very committed people, which is great. And that's part of the thing that drives you on. It's kind of gets you out of bed in the morning because you think, well, even if I'm having a kind of down day, I can't sort of show that because there's this amazingly committed team and we've got deadlines. We need to make it happen. And so it does, we've kind of, as we'll probably move on to, we've kind of managed to achieve something that no one else has achieved globally, which is the regulatory approval.
Well, let's dive into that. So, as you just alluded to, you've achieved something absolutely remarkable and pretty unheard of in this space. So, I'll open that floor to you.
Yeah, and again, that was no easy ride. I mean, we've been through this kind of process with auditors for probably like 6 years now. So it wasn't like let's get a CE mark, ping, job done, because no one's done one before. So they don't have any kind of recipe for how to award a CE mark. So we had to really work on building our evidence from the kind of ground upwards. And then we've also looked for what you'd call predicate technologies or other ways of solving the problems that we're solving, so that we can demonstrate that we are what they call non-inferior, basically, so that you can kind of say that we do just as good a job of blood pressure as these other technologies do. But that's like taken a huge amount of learning and iteration. We also have to run a small company like you would a large company, because we have the regulatory process, a quality management system. So sometimes it feels like we're in this juggernaut when actually it's a lean, small, agile business. And that's true for a lot of other tech companies now who are facing, whether it's medical regulation or banking or in kind of other sectors. It's kind of a new thing that it's good because you take a like risk-based approach to what you're doing. And if you get it right, it differentiates you from the people who haven't achieved that.
I mean, something that occurred to me there was because of the sheer volume of things that you need to learn, challenges that you need to overcome, regulatory, all of that sort of stuff. How did you pick up these skills as you went along the way? Obviously, I know that you mentioned you had an incredibly diverse team, but you're ultimately steering the ship. How did you find that element of kind of that journey?
I think it probably suits my personality. I've always been like a jack of all trades, master of none, and I've always preferred that kind of higher level view of things. And also, in turn, kind of valued expertise. So it's about assembling the expertise that you need. And sometimes that changes through the journey as well. So some of the earlier expertise may not be so relevant as things become more business as usual and processes. Then you need to move some things into experienced hands who are good at kind of running processes and operating things. So it's like a moving feast. I always think when we started out, it was a bit like a heist movie where you kind of assemble a group of people you know through your own network. If you know what I mean, it's like, you know,
Like
you see
the
these,
Italian
like,
job, but for
Ocean's
health.
11 or Italian job. You know, it's like sort of, okay, we know the guy that blows safes, we know the guy who can
The
drive,
acrobat,
the driver,
yeah.
we've got the getaway driver, we've got the, you know, the tech guy. And it was a bit like that to begin with, because you know, until you can afford things like search agencies and to do things like a bigger company, a grown-up business, you're reliant on your network. So, and that's kind of part of it as well. It's been that journey of moving from the kind of slightly chaotic startup, early days startup, into this much more formalized. We're now like a medical device business. So we don't manufacture stuff, but everything we are audited on is like, we want to come and see your premises and review everything you're doing. So it's like we have to be a lot more formal, and we have to be able to kind of follow these processes from a quality perspective. So that's been like a big learning curve. But the reward is we've got a Class 2A medical device in pure software. So Lifelight is just a piece of software that's running on your phone, and it's doing the job of a physical blood pressure cuff or a wearable watch.
Which is utterly remarkable. So you've achieved all the bits and pieces that you wanted to achieve from a technical standpoint.
Yeah.
What was the approach next in terms of commerciality, taking this to market?
So it's an interesting thing, because we, throughout the development of the tech, we've been engaging with different types of partners, different companies. So we actually had this kind of waiting list, if you like, of people really keen to integrate Lifelight and use it in different kind of verticals or use cases. And that was really important in its development, to understand what their requirements were going to be. Because I didn't want to do the classic thing of you build something and then hope people will come. It's like you need to make sure it's going to be fit for purpose, that it has a commercial kind of relevance. So from the beginning, I had this idea of it being like a Lego brick that plugs into other people's platforms. And that goes back a bit to my background in health tech, because there was this big trend around like healthcare analytics, looking at big data. Big data was like the phrase, like in the 2010s. But nobody, you know, I kept asking people, where are you going to get this big data from? And then it was like, oh, Internet of Things. Well, what things? You know, where are these things? Who's got the things? And nobody had an answer. So the reality was all the health data was after you've been in hospital, because that was the only place where people really collected data. I mean, we've got primary care, but that literally is when you have an intervention. So again, it's a bit sick care. Is when you're not well and you go and visit your GP, something will get recorded on your medical record. But there's no like sort of leading indicators. There's nothing that could be used for, you know, at that moment in time, they would take a blood pressure, they would maybe do a blood test. So there'd be a few little pointers, but who was looking at that data and how is it being tracked, not being tracked longitudinally? So that was the other piece. I thought, well, there's all these platforms being developed in what they call remote monitoring, telehealth, all of these kind of things. And at the moment, they were dependent on kits. So people were doing this thing of saying, let's monitor people with chronic diseases at home. Okay, to do that, we need to send them a whole bunch of stuff. We need to send them Bluetooth blood pressure monitor, for example, tell them how to do it. And then what you find is people don't follow the instructions. And then you need a call center to nag them, ring them every morning. Mrs. Smith, you haven't done your blood pressure yet. We haven't seen the number. Make sure you put the cuff on the right way around, because that's a common problem. 90% of people don't use the cuff properly. Mm-hmm. So they're like doing all this like very kind of labor intensive work, which made the whole economics quite marginal, because you're investing differently. Instead of having people in hospital, you're spending a huge amount just to keep them out of hospital. And so that was like, wow, imagine if we just replaced all of that with a software plugin and the patient just uses their own phone. So that was kind of my first thinking for a use case for Lifelight. But then really, I hadn't really kind of also considered this massive opportunity of reaching the unreached. So this is like the health screening, or what we call case finding, more accurately. So it's like finding the unfound. And so that's like so we had partners interested in both. Right from the get-go, in terms of when we had our Class 2A approval last year, we already had like a long list of people that we just reconnected with and said, remember guys talking to us 5 years ago, and you said, give us a call when you get Class 2. We've got Class 2. And so it was a really interesting kind of explosion of, of testing, lots of due diligence. People kind of want to know that this is going to work properly before they risk it with their patients, quite rightly. There's the whole cyber kind of integration, making sure it's safe technically. But we've got there. So we've got some really cool deployments and partnerships working now. Particularly like the first ones have been in insurance, in sort of private medical insurance in Spain, for example. Literally in the last couple of weeks, DKV, our partner there, have gone live with a hypertension pathway using Lifelight in their patient-facing app. So that's really exciting for us because we're going to begin to get events data, begin to see how people use and interact with the product.
I mean, I see so many applications for this. I mean, I think about some of the projects that we've been involved in, even from kind of just a basic e-commerce, for want of a better term. You know, when we were thinking, we did a project with Lloyd's Pharmacy Online Doctor, for example, and, you know, one of the barriers is always that you still had to go in when you wanted your repeat prescription. If you were after the contraceptive pill, for example, should be pretty simple enough to get, but you'd have to go into a pharmacy to have your blood pressure taken and things like that. And the whole point of it being a convenient service that you could phone or kind of do online was that you didn't have those barriers. So you're removing so many of those barriers for people being able to access levels of care. I guess you've got these partnerships with these commercial entities and insurance as well. I mean, that's another huge thing in terms of people being able to lower their premiums, for example. You know, you're doing a screening, you can do it much more regularly, you can submit those kind of data points more regularly. From a B2C, so direct consumer aspect, is there any sort of ambition or play there that you're thinking about? And, you know, not just kind of partnering with organizations, but are you thinking about the more direct route?
Yeah, I mean, that was always the ultimate game plan, really, was to look for, let's work with partners, let's learn what works, what doesn't work. And then we can apply that knowledge to B2C. So we try and get things as best we can right first time. And so it's a really exciting time because we're just launching a B2C app. But that's almost like, it's kind of depressing in a way because it feels like we're at the beginning of most app companies' journeys. Like, let's build it, and then you do an MVP, you test it with people, you get feedback, you can iterate. But it's also really exciting to have that opportunity to begin to put this into end users' hands and have the freedom to kind of listen to them, modify it, give people what they want. So it's really, and it actually was born out of two things. One was the NHS, who we've worked really closely with. They've been amazing for our clinical trials. We've worked with some incredible trusts and research people. And when we engage with the obvious thing, which is GPs, so primary care, looking at population health, how do we find the hypertensives? There's no money for prevention. And it's really frustrating because, you know, it's part of the kind of government's 10-year plan for healthcare is this like move from analog. We literally sit in the middle of that because it's analog to digital. We're moving from physical blood pressure to digital blood pressure. It's like from fixing to prevention, which is exactly what you're doing. My passion around, let's get away from sick care into preventative. And it's moving from hospital to community and home, which is, again, our story. It's like, let's just keep people out of hospital. So you'd think, amazing, we're really aligned. But the funding doesn't follow that. The funding's still funding the old model because it needs to, because there are so many broken people, if you like, people arriving at A&E, people in beds. And so, as always, the funding just goes into the fixing side. It's something like 90% of healthcare budget goes into, if you like, the acute, the hospital and primarily long-term condition management, but actually treating people when they've had adverse events as opposed to keeping them healthy and at home. So it's a really tough battle, and that's where, sorry, that's a long-winded answer for
no, it
actually,
makes complete sense.
What happens now is you go to a GP, they do your blood pressure, and then they say, go and see a pharmacy or buy a cuff. So they're actually like, it's a patient pay model right now to do your blood pressure at home. It's actually, you need to go and get a cuff, and then they have some, you know, then you could sort of say, well, that's like, what about health inequalities? If, you know, what if people can't afford a cuff? Well, there are like projects for health inequalities, so they could provide tokens for people to have the B2C app paid for if you're eligible under a particular program. So it shouldn't be exclusive. It shouldn't be just for those who can afford it. But the idea is, and then we're not kind of blocked by waiting for preventative funding. We're not blocked by all of the challenges that you face in waiting for the NHS to catch up with the new policy changes. And also, the second benefit is with our B2B partners. What we've discovered is there's a huge amount of due diligence needed before we add Lifelight into a third-party application. You're kind of talking about some of these platforms have 3 million, 20 million users. You do not want to break their kind of primary, and if it's a commercial business, that's going to cost them huge amounts of revenue as well as reputational damage. So quite rightly, they want to go through a really robust due diligence process.
I mean, it's one of the crazy things that obviously we do talk a lot about cancer and the research that goes into that, but cardiovascular disease is still the biggest killer globally. And so this is why it brings all the more into focus the importance of Lifelight and its potential impact, not just, as you said, in the UK, more globally speaking.
Yeah, it's interesting, isn't it? Because I've wondered about this, that there's a genuine kind of fear of cancer, isn't there? And it's kind of palpable, and quite rightly too. I think that people need to be aware of, kind of the kind of steps they can take. But it's like, where's the cardiovascular risk? Where's the awareness of the damage that our bodies are getting from lifestyle, etc.? It's kind of it seems it's sort of disproportionate, isn't it, to the kind of actual statistics?
It really does, and the fact that, as you said, it's asymptomatic. You don't really know. You could be doing all the right things.
Yeah.
We have the tools at our disposal to be able to do this. We just lack the education and awareness around these topics, and there does need to be a step change in that. I completely agree with you on that. In terms of those next steps and the things that you're hoping to see with Lifelight, the progression that it's going to make as you launch the B2C app.
Yeah.
What is that kind of next hope for you? What's that next step?
Well, we've got some really exciting stuff planned. I can't talk about all of it because it involves some kind of commercial partnerships. But the concepts are that we want to be kind of, if you like, ride the wave of some of the publicity around awareness of numbers. So in the past, various charities, maybe pharmaceutical companies, and others and public health initiatives are kind of pushing out maybe digital social campaigns. But the call to action is just go check your blood pressure. And so the kind of uptake, first of all, they don't know, they can't measure the uptake, so they don't know how many people actually sort of heed the call, as it were. But also, we can predict it's probably quite low. And I think that's the exciting thing. So these partnerships, we'll be able to give them a measurable, the call to action will be, well, check now, just use Lifelight. So then we have the opportunity to engage with all these potentially millions of new users checking their blood pressure for the first time. And then we can establish a relationship with our B2C app with them. And if they want to, they could subscribe over a longer period. But at the same time, the main point is they have that initial contact and they can try and become aware of their numbers. And then depending on the nature of that partnership, we're really keen to make sure there is a so what, so that if somebody does have elevated blood pressure, first of all, you don't scare them, but you reassure them, and then they're taken into a pathway. Either it's a check for a few more days and then kind of engage with a pharmacy or with their GP, or if it's an insurer with their insurers. And it's that kind of understanding the right pathway for the context of the individual. But that's one of our kind of routes, and those are pretty big. Looking more to the future, we're really excited about opportunities where there's massive untapped kind of potential, like looking at the African kind of nations and understanding where there's a culture of micropayments. It's really interesting. So cardiovascular disease prevalence is huge in Africa, particularly sort of states like Nigeria, and yet the access to healthcare is really low. And what you have is a culture of, in some of the more remote parts, you'll find people will go to a guy on a street corner in a market and use a few minutes of their mobile phone to call somebody, because then you don't have to pay a whole subscription. or buy a phone of your own. What if you could do that and have your blood pressure checked for a few pennies kind of thing? But as long as there's like a so what, so you can then have easy access to like a charity or somebody or a health organisation who can provide the kind of follow-up that you need. Those are kind of exciting things for me. And India's another one with 1 billion smartphones and yet limited access to healthcare. And this is where you see real innovation in these countries where you can leapfrog all of the traditional ways of doing healthcare and say, actually, we now have this kind of mobile, literate generation and massive ubiquity of kind of access to smartphones. Like, how can we leverage that and use it for good?
Yeah, which would be a remarkable step change from, I think, the way that people feel about their devices currently.
Yeah.
Which is, if anything, not bringing a lot of happiness or a lot of benefit. So that's a remarkable mission. And actually, as you were speaking there, made me think of one thing that has, unfortunately, bringing this back to my dad, that came along for the ride is vascular dementia. And unfortunately, that's as a result of the stroke. And it also then made me realise that there is a whole swathe of adjacent conditions here that there is an opportunity to play a proactive part in and a meaningful part in. So it's remarkable work that you're doing, and thank you so much for doing it.
Well, thank you.
To find out more about Lifelight, Laurence and the team behind the innovation, visit lifelight.ai.